1, 2, 3, 4, and 6. 5 will become obsolete. Now, so we are dividing pharyngeal arches into ectodermal cleft. Yes. This brownish part over here is the mesenchyme. This yellowish part over here is the endodermal outpouching. Fine. All right. Yes. Now, what we are going to learn concerning the embryology of ear here, we are going to learn how external middle ear forms and how can you remember the subtle difference between the important embryological structures. Fine. Now, let me put it this way. So, ear has been modified as structure from the first pharyngeal arch. Now, the first pharyngeal arch, you think like this. This is a brown is the ectodermal derivative. This violet is the endodermal derivative. So these will come from outside. This will come from inside. Both will fuse with the mesenchyme. So this structures will form from mesenchyme. This structure will form endodermal outpouching. This will form from the ectoderm. So what are those structures? I'm going to compare this with our actual ear that we are studying. So doesn't it look like an external auditory canal? Does these three structures, doesn't it look like ossicles? Doesn't it look like a cavity which is covering the ossicle? Yes. To be precise, my dear students, I want you to understand this one means outside. EAC, external auditory canal, comes from outside, ectodermal cleft. Next one. The structures of the middle ear, which is ossicles plus muscles. This, the ossicles and muscles develops from mesenchyme. All right. Whereas the cavity which is surrounding the important structures of the middle ear is called middle ear cavity, and the continuity of middle ear cavity leads into an important tube, eustachian tube. Gotcha, my boys? All right. Now, let us summarize all the important things, and also let me make it clear what are the recent changes in this embryology. So, have the workbook. If it doesn't have a workbook, please look into this particular table over here. Pinna. So pinna, just leave away pinna. It's outermost structure. Okay. First, we'll start with external auditory canal. It is ectoderm, which is first ectoderm cleft. I'll just write it one by one. Then I'll slowly add upon the latest advancements in these topics. So middle ear cleft and eustachian tube develops into first endodermal outpouch. The tympanic membrane. So all these layers unite to form the tympanic membrane. So it is all three layers. Malleus incus, mesenchyme, but it is first arch. Stapes foot plate, stapes suprastructure. To be precise, again mesenchyme. Second arch mesenchyme. Stapes foot plate, annular ligament develops from bony labyrinth. Okay, this forms from otic capsule. This membranous labyrinth forms from otic vesicle. So previously, when fishes were there, inner ear was there, which was meant for balance. So these two structures were already present in the fishes, which means these two develops closely associated with brain, which is neural ectoderm. This neural ectoderm. Understand? So what about the pinna? The pinna develops from again mesenchyme. First arch and second arch together will form. So first arch forms tragus, the second arch rest of pinna. So all these will form into 6 mound-like structure like this. Hillocks of this. Okay. Now the latest advancement, exnotory canal. Some are saying that this ectodermal cleft not only contributes to the exnotory canal, this mesenchyme itself contributes to the exnotory canal. So first arch mesenchyme also contribute to the exnotory canal. So this latest advancement given few of the anatomy books, not updated in ENT books. Understood? Answer for this question is 1. Second question, which is INICET 2024 repeat. Which of the following is not associated with arteritis media with effusion? And options are AD type of tympanometry curve, mostly bilateral. It resolves on its own after cold subsides, generally associated with common cold but can develop de novo. What is the correct answer, my dear students? Not associated. Yes. Yes, Dr. Sumishri. Yes, Dr. Tamil. Yes. A lot of you are answering brilliantly. So, what happened? Yes. Yes, 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 yes. So, there is a little bit of confusion from first option to second option. The recent INICET question. So, I kept a repeat here. Let's, first of all, the answer for this question is this is not associated with arteritis media with effusion. Why? The curve which we could relate with arteritis media with effusion are otherwise called serous arteritis media. Okay. Serous arteritis media is a B type of. So we are talking about tympanometry, we are not talking about any other investigation. So in tympanometry or impedance audiometry, the type of curve that you observe in serous arteritis media is B type of curve. So it's a flat. So this is not correct. Okay. Okay. What about a serous arteritis media? Why these INICET people is so much fond of such a small topic? Because strategically speaking, a topic where a nasopharynx can get affected, but it affects the ear. For that reason, they are repeatedly asking questions. Every year they are asking at least one question from serous arteritis media or arteritis media diffusion. Okay. Fine. So in our OPD, being a consultant, we will see a lot of patients, be it from 1-year kid to even 100-year-old grandma. Am I right? A 100-year-old grandma can have a sensory neural hearing loss. She said I could have hard of hearing only for last 2 days. 100 years grandma, hard of hearing 2 days. Whether it is acceptable? No. It's age-related hearing loss, which should have present for at least 20 or 30 years, considering her age. A 1 year small infant can also present. So, a 3-year toddler is present to my OPD. Okay, that toddler will not talk with me. That toddler will sing only rhymes with me. Okay, just think of this particular situation. The toddler is coming to my OPD. It is singing rhymes. Johnny. The name of toddler is Johnny. Johnny. Yes, doctor. Feeling sleepy. Yes, doctor. Snory. Yes, doctor. Hearing less. Yes, doctor. So this, I have asked the leading question to that kid in the form of a rhymes, nursery rhymes. So I started and asking other questions. Eating ice cream? No, doctor. Telling lies? No, doctor. Open your mouth? Ha ha ha. So this is Johnny. You look at Johnny. What is this facial appearance of Johnny? Can someone say this? Eyes wide open, sunken, broad nose. The upper teeth is not normal. It is been coming out a little bit crowded. Open mouth. This is all about Johnny. So if Johnny is coming to you and singing rhymes, you also better sing rhymes. So let's discuss about this adenoid hypertrophy, which is the cause for serous otitis media. So see here, serous otitis media causes in case of children, very important, adenoid hypertrophy, or else they may give in the history about an adenoid phasis, a child coming to you with snoring, frequent disturbance of sleep, eyes are sunken, wide nose. So every other feature of adenoid phasis can be asked as a clinical question. So children, you should look for adenoid hypertrophy. Fine. The next one, adults. In adults, you should look for carcinoma nasopharynx. Carcinoma nasopharynx. Fine. Yes. So why so? Basic thing you have to understand is the name is otitis media, but the prefix is serous, which means if you see serous anywhere in the body, which means there is no infection. Mean no infection whatsoever. No infection whatsoever. So which means we are having an eustachian tube which is maintaining the pressure of the middle ear. This is middle ear. This is eustachian tube. This is nasopharynx, which is 36 millimeter in length. A flexible tube, which is horizontal in case of children, vertical, a little bit transverse in case of adults. So that itself makes the children more prone for aspiration of the milk into the middle ear through the eustachian tube. That is another MCQ. Now, looking into this particular scenario, here is an eustachian tube which connects middle ear with that of nasopharynx. So this air between these two should be absolutely equal. If the air is not equal, it could lead to blockage of the eustachian tube. So what leads to the blockage of eustachian tube? So here, a mass that could occupy the nasopharynx lead to blockage of the eustachian tube. So it could be, in case of children, adenoid hypertrophy. In case of adults, could be carcinoma nasopharynx. It leads to negative pressure in the middle ear. The negative pressure in the middle ear leads to serous fluid accumulation. The serous fluid accumulation leads to serous otitis media. or OME, otitis media percussion, or blue ear or blue ear. So the causes are very clear. What is the appearance of the tympanic membrane clinical? See here, it is a blue ear. See here, this is water with air bubbles behind tympanic membrane. Behind tympanic membrane. Now, what is an audiometry? See, it's very important. Please don't dive into the thought that it is always type B. In the question, if they ask you, a child is coming to you with the complaints of hard of hearing or ear blocking sensation. No, not hard of hearing, ear blocking sensation. On seeing the tympanic membrane, you could notice retracted tympanic membrane. So, retracted tympanic membrane complaints of ear blocking sensation. So this is a typical case of E-station tube dysfunction, which is the initiator or trigger factor for a serous otitis media. Be it whatever cause, ulnar hypertrophy or CNS reference. E-station tube dysfunction, which is an early, ask you like this. The child is having ulnar phases, but she is having only retracted TM with type C tympanometry. Again, that should be the case of serous otitis media early stage. So early SOM, you can write it as early stage of SOM. Please make a note of it. They can ask a question like this. So it is day 1 or day 2 of SOM. You cannot find clear fluid behind TM. It is just retracted TM. Early station dysfunction, early SOM. The curve is type C, which is negative curve. That is negative curve. Type B, it is late SOM. The curve will be flat curve. Right? Treatment in case of ulnar hypertrophy, what you are going to do? Ulnar hypertrophy, you are going to do adenoidectomy with grommet insertion. Okay, it's very important. In case of adults, you should be doing biopsy followed by treating the tumor, not addressing the serous otitis media. It's a very small problem considering the severity of CNS pharynx. Treating the tumor. Right. Next, INICET 2022 repeat. I placed it here. 50 years female present with hard of hearing and she had following audiogram patterns. What will be renamed? It's such a brilliant question, easy and simple question. They have inserted a lot of concepts into this particular question. So you should be knowing what is Rene, what is Weber's, and you should be knowing what are the audiogram patterns. All right? Yes. So the answer for this question, and also what is Rene, what is Weber, and what is this particular audiogram suggest. See, first we'll start with audiogram. I will tell you 3 thumb rules for audiogram. Thumb rule number 1 is hearing loss is there if there is a curve, any curve, be it a bone conduction curve or an air conduction curve, any curve more than a 25 decibel range is hearing loss. Next one, the bone conduction curve. Bone conduction curve, if it is more than 25 decibel mark, please pay attention, my dear students, very important. There is confirmation of sensory neural. Please pay attention. So go one by one. The thumb rule is very important. Don't skip the steps. Third thumb rule is air bone gap. So the gap between air conduction curve and bone conduction curve is more than 10 decibel. It is conductive. It is conductive. Okay. The air bone gap is more than 10 decibel. It is conductive. So let's apply these 3 thumb rules. Okay. So first, you have to understand the air conduction curve will be continuous. Bone conduction curve will be discontinuous or broken. Right will be red color. Left will be blue color. Then you will have 0x. This is for air conduction. Less than or greater than bracket for bone conduction. All right. Understood? Yes. Now, so let's apply the thumb rules. Okay. The thumb rule number 1. This is the 25 decibel range. I'm sorry. So this is the 25 decibel range. So here, this is 25 decibel range. Here, what you're having, both the curves more than 25 decibel. Hearing loss is present. That confirms thumb rule number 1. Number 2, you are having bone conduction more than 25 decibel. That is again satisfying thumb rule number 2. So you are having sensory neural hearing loss. Thumb rule number 3, air bone gap less than 10 decibel. So there is little bit gap between air and bone conduction curves. That makes it a clear-cut case of severe sensory neural hearing loss. Next one, again I'll draw a line. First one, any curve more than 25 decibel, hearing loss is present. Bone conduction less than 25 decibel, no sensory neural hearing loss. Number 3, see the airborne gap. Please pay attention. Airborne gap more than 10 decibel. Yes, airborne gap is more than 10 decibel. It is a clear-cut case of conductive. Very, very important case of current hearing loss. Number 3, see here. First one, hearing loss. Yes, of course, hearing loss is present. Number 2, see here. After the curve, you are having sensory neural picture, which is bone conduction curve more than 25 decibel. It is a clear-cut case of sensory neural hearing loss. The third one, you are having air-bone gap more than 10 decibel. A-B gap, which is more than 10 decibel. It is a clear-cut case of conductive. Case of conductive, which means a patient, a 65 years old male coming to with ear discharge as well as the age-related hearing loss. That could happen a lot of times, which means it's a case of mixed loss. That completes our learning about audiometry. 3 thumb rules. Always remember, hearing loss, present or absent. Even they could give some normal curve. Please don't come to the judgment without even reading the question that there is some hearing loss is present. It can also be normal. So normal means less than 20 decibel. Abnormal means more than. No, I could definitely say it is 25 decibel. It is not 15 decibel. It is not 15 decibel. It is 25 decibel. Okay. That's what we use as a standard protocol, 25 decibel. No doubt in this. Fine. Okay. Then the bone conduction curve more than 25 decibel. Air-bone gap 10 decibel is enough. Okay. Air-bone gap. Okay. Hearing loss. Second thumb rule more than 25 decibel. Third is air-bone gap more than 10 decibel. Understood? Okay. Fine. Let's get into the Rinne's test. Rinne's test. Here we are placing the tuning fork over the mastoid process, then in front of the ears. Compare the bone conduction with the air conduction. Air conduction better than bone conduction. It is Rinne's positive. Very, very, very important. It could see in normal persons as well as sensor loss bone. In conductive loss, bone conduction better than air conduction, which is the patient, even after placing in front of the ears, he can't hear in front of the ears. Here, bone conduction is better than air conduction. Rinne's negative. Very, very, very important. And also, you look lateralized to the affected ear in case of BPOS. So if you want to diagnose conductive hearing loss, you have to remember these 2 points. If you remember these 2 points, you could answer any tuning focus correctly. Rinne negative conductive hearing loss. Lateralized to affected ear, it is BPOS. Okay. Then it could confirm it with ABC. ABC is only for sensory neural hearing loss. ABC and Schwabach only for sensory. This table I have taken from Dingra textbook. So ABC is only for SNHL loss. Okay. Now, with this knowledge, let us combine these 2, audiogram as well as tuning fork. Now, this particular picture, here, I'll tell you one important rule. One important rule. Please understand. If you are reading an audiogram graph, you are seeing one left-sided curve, okay? Left-sided curve, which is plotted in blue, having a bone conduction curve as well as air conduction curve. But you are not finding any bone conduction curve for the opposite normal side. Now, you please don't take it as a printing mistake or examiner's mistake. It means that this you could use it as common for both the ears. I will repeat the same point. See, if the bone conduction curve is given for only one side of the ear, it's not given for opposite normal side, which means that one bone conduction can kept as same for both the ears. Here, this is bone conduction for right ear also. So here, if you keep this as a bone conduction for right ear, so it is absolutely normal. Right side is normal. Red is normal. Blue is having, so blue is having what? Please answer. 3 thumb rules. Thumb rule number 1, hearing loss is present. Thumb rule number 2 is bone conduction curve less than 25 decibel, no SNH loss. Thumb rule number 3, A-B gap more than 10 decibel. A-B gap more than 10 decibel. So what picture we are getting from this particular audiogram that is given in the question? Please answer. Please answer. So here I am quoting a question which is having an audiogram. Hearing loss is present. Bone conduction curve is normal. Air bone gap more than 10 decibel. What sort of hearing loss is this? Please answer. Hello. Hello. Yes. See, airborne gap more than 10 decibel, Dr. Veda. It is not less than 10 decibel. This is a case of conductive hearing loss, Dr. Veda. Now, for conductive hearing loss, what is the RINA and positive? What is the RINA? So, which side is affected? Which side is affected? Right is normal, left is affected. So, it's a left-sided conductive hearing loss. No problem in this. Left conductive hearing loss. Okay. So if it is a left conductive hearing loss, we should be looking for left RINA negative, Weber's late lies to left. Can you find this answer? Left RINA negative, Weber's late lies to right is given. So we leave this. Left RINA negative, so no option is there. So left RINA negative, Weber's late lies to left is not in the option. So what could be the answer? See, it could be left RINA negative, right RINA positive. Is it not the case, my dear students? So it's right RINA positive, Weber's late lies to left. So you don't look at the pathological side always. They may even give the normal side. Okay. So left is pathological. I don't deny that fact, but left is negative, right is positive. So Weber's late lies to left. Option C is perfectly correct. Yes. Very important question. So we'll solve few more MCQs from this particular thing. A 65-year-old male because comes to ENT OPD and he says he could understand only shouted or amplified speech. The degree of hearing loss. INICET 23 review. What is the degree of hearing loss? See, we are having WHO classification for hearing loss, which says that 0 to 25 is normal, 26 to 40 is mild hearing loss, 41 to 55 is moderate hearing loss, 56 to 70 it is moderately severe, 71 to 91 is severe, above 91 it is profound. Now, we are equating this with that of a normal practical usage of conversations. See, what is equal to mild? Difficulty with mild speech. Your friend is whispering something in your ears. You are not able to hear that. You may have mild hearing loss due to serious auditory media. Frequent difficulty with normal speech. Your mother or father in 50 to 60 years of age group, they deny the fact they are not having hearing loss. They could fall into this particular category. moderate hearing loss. Frequent difficulty with normal speech. You are saying normally, that is not understood by your mother or father. The next one, moderately severe. Frequently difficult even with loud speech. This may be your 55 to 65 grandma, grandpa, or uncle or aunt. So frequent difficulty even with loud speech. You have to understand 71 to 91 is severe, can understand only amplified speech. So how you have to understand? Mild is faint speech. This severe is shouted or amplified speech. You should remember these two only. Rest all falls between or after. Okay, you remember these two. Mild means difficulty with faint speech. Severe means can't understand, can understand only shouted or amplified speech. Okay. So less than that, greater than that required. So what is given in the question? What is the answer for this question? So it is a case of frequent difficulty even with loud speech. It is a clear cut of moderately severe. Wait. Give me a clue. He can understand shouted or amplified speech. Okay, he can only understand shouted or amplified speech. It's a case of severe hearing loss. Okay, it's a case of severe hearing loss. Okay, that's why he can understand. Okay, that's why how to keep it in mind. You can understand. So can understand shouted speech, severe. Cannot understand even faint speech, mild. These two parameters you could easily remember. Less than that, moderately severe, moderate. More than that, profound. Okay. The answer for this question is severe hearing loss. The answer for this question is severe hearing loss. So again, a question from INICET 23 repeat. 55 years old woman with the complaints of tinnitus and progressive hearing loss with episodes of vertigo. The Butone audiogram is as follows. She is most likely suffering from. What is the answer for this question? So this is an audiogram. Whether you're having hearing loss, absolutely. If you're having a hearing loss, thumbrule number 1 is